All right. Hello, everybody. Welcome to Grand Rounds. And in our new Zoom format, thrilled to have another guest speaker from not all the way across the country, but halfway across the country. Today's speaker is Benji Mathews, who's the Chief of Hospital Medicine and also the Director of the Point of Care Ultrasound Program for Hospital Medicine at Health Partners in Minnesota, and an Associate Professor at the University of Minnesota Medical School. And most recently, the course director for the 2020 Society of Hospital Medicine annual meeting. He has a particular interest in quality of care issues and also around diversity, equity, and inclusion, and serving as an advocate for immigrant physicians. So we're delighted in particular to have him today to talk about structural racism and bias in medicine during these two pandemics. Dr. Mathews.
Thanks for the invite. Thanks, Dr. Weissman and team, chief residents and all. I appreciate it. I know it's a virtual era, so this is going to be challenging for many. I'd love to have seen you in person. I would like to disclose before any talk, or at least I say to myself and often to the audience, that any talk that I prepare is really a talk that I give for me too. So especially in a topic we're going to go into today, instead of seeing this as me talking in my brown skin, I'm an immigrant healthcare worker in a leadership role. I do a couple talks here and there on diversity, equity. Instead of me telling this group what to do or not to do, I see it as a huddle, a virtual huddle, thinking about ways we could do things and be better together. So area I'm learning in and unlearning about the topic, so glad to journey with you on this. So this slide, depending on the talk I provide, if it's on structural aspects of racism, I have learned to do this slide. And it's a land acknowledgement to both pause and provide a growing context into this talk. So since I am from Minnesota, and I'm in Minnesota here, I wanted to acknowledge the seized territory of the Dakota people. These people and their descendants are still among us and still have consequences of prior and current structural bias and historic marked oppression. So I would encourage you to look into the origins of your land and maybe where you're gathering on right now as well. So my hope is to help reshape some of our discourse, culture, language in a way that can really commit us to take action towards systemic reconciliation. Disclosures, I have a lot of support from some of my colleagues, Dr. Chomolo, who have did shared presentations on this a couple times, and gratitude to some of our national mentors, Dr. Manning and Dr. Jones, for their expertise and frameworks, which is a lot of it's what I'm borrowing from for this talk as well. And this is at best a brief overview of the content. So if you're coming in here to hear all aspects or specific aspects, you may leave here nice and disappointed. And maybe some of you still will. And I apologize early for that. Tried to pack in a lot, but needed to choose some angles based on some of the feedback I received from some of your faculty on what direction you wanted to go with this. So these are the areas I won't cover in depth, though I encourage you to be familiar with: how we form racial bias, concepts such as stereotype, threat, white privilege, fragility. We will touch briefly on some of these. Many of the other topics we'll have to get to at another time. So what I'm hoping to accomplish, a quick roadmap, beginning to understand how structural racism works in medicine. We'll do a couple storytelling here and there. How our own bias can contribute to racial inequities. And I think many of you have been working in different pockets in your organization to learn this. So hopefully it's not absolutely new, but still coming together to rethink on a topic that's tough to talk about is important. I'll try to leave some question and answer session in the end here. Begin to work on becoming more anti-racist ourselves and how to help our hospitals and systems become more anti-racist. A lot of the talks historically, maybe even a decade ago, is really about identifying disparities. However, the challenge, I think, is that does not get at the underlying root. It really gets at the symptoms. So the problem is much more broad than that. And I'm grateful for the work that has been done before from ACP and other groups on the subject and many of the publications, but we have to dive a little deeper. So while we often talk about racism, people have this potential view in their mind, right? Potential explicit, visible acts of bigotry. But racism is a lot more than that, and I think this is what this talk wanted to get at a little bit more. this diagram, I think, depicts that iceberg. We're at the tip, and those are often when you get these explicit acts, but racism often gets in so many other ways in our lives. So some of these things are hidden and unaware, and people are benefiting from the structures that it has been created from it. I don't know if you've known the work of Dr. Camara Jones. I've really enjoyed her work, and the former president of the American Public Health Association uses an allegory titled The Gardener's Tale, and to help really understand the role that racism plays in our society, including the health system. So a gardener has two flower boxes, one that shows she is full of, it's full of good soil, and the other one she knows is full of bad soil. What happens is over time, the flowers drop seeds into the same environment and the same result happens. And over decades later, and it's, I think, 10 years in the paper, the gardener returns and believes that she was right to prefer the red flowers over the pink flowers. It really fails to understand the pink flowers really got a lifetime of poor growth because it was planted in poor soil, right? And so that gets at the basic root of things. And then moving into the personally mediated racism piece here, the gardener then plucks the pink blossom before they can seed because she doesn't like how they look. Or similarly, if a pink seed happens to be in the land in the red flower box, the gardener pulls it out and sets before it can set its roots and benefit from that fertile environment. And then the internalized racism piece. So this gets a little imaginary, right? As a bee is pollinating those flowers, the pink flowers yell out, "Don't give me that pink pollen, give me that red pollen," right? And so as they see that red flowers flourishing. So this reflects that erosion of value and how there's a want to be a part of the privileged group a lot more than the unprivileged group. So I was thinking of an example, and this happens to many of us in the brown and black communities. A vivid example of when I was moved to the city, and it was great to see a lot more people that looked like me from an immigrant brown community and a person of color. And I saw across the room in a restaurant here in a bar setting, there was a large group, and in that room it was mostly Caucasian white, but there was a subgroup of brown people. And I said to someone that looks like me, maybe I want to hear their story. But when I started approaching that person, I could see him turning and almost in a different way, engaging more with the white majority friends there. And this pattern continued as I went into different pockets in that restaurant. And then as I globally went in throughout the cities, I've seen that happens a fair bit. And certain brown and black people in Minneapolis were wanting to be part of that privileged group. And me coming from that potentially historically under-resourced or group or biased that way, they wanted to shy away from that. So that did hit hard. So this happens more often than not. Racial bias, it starts rather early. So this slide really gets at that subtle racial behaviors of any ethnic groups really can occur pretty early. And honestly, I'm married to a pediatrician, and it's internalized as early as 3 years old is what the literature has been showing. Touching on some of these terms, privilege. One of the better definitions I've heard is off Twitter. For those of you guys not on Twitter, and sometimes it's helpful. And so this is where I think some of the med Twitter work is pretty impressive. So white privilege does not mean your life hasn't been hard. It means that your skin color isn't one of the things making it harder. So can I apply this to other forms of privilege? Male privilege, for me, and for those who identify as males, doesn't mean my life has no hardships or has not been hard, but my gender has not made it harder. So rapid fire talk here. So I'm going to walk through a couple of these pieces and structural roots of racism in medicine. In the 19th century, prominent docs sought to establish these physical peculiarities of Black Americans, Indian Americans, etc., to serve to distinguish them from the white man. And so this is an illustration of Dr. Marion Sims, and Dr. Marion Sims was one of the founders of OB-GYN. One of the reasons he was in that position was because he discovered a procedure to help with the fistulas in the vagina and bladder that happened right after birth. And the way he designed and perfected, if you will, this procedure was experimenting on his slaves. without anesthesia at a time when that was the standard of care. And with the name Anarcha is believed to be the name of the slave subjected here in this picture to 30 experimental surgeries. And I really think this speaks to much of what has not been taught in medical schools throughout our nation, especially 10 to 15 years ago when I was going through the training system. Medical schools historically have excluded Black students, and even eventually when they did allow people of color, professional societies barred Black doctors. And this talk is more than brown and Black. There's a lot larger set of diversity and racism, but we may focus a little bit on our Black American communities here. Most hospitals and health clinics segregated Black patients. Federal health policy was designed both implicitly and explicitly to exclude Black Americans. Access to good medical care is predicated on what? A system of this employer-based insurance. That's hard for Black and brown Americans to get. And so they were denied most of the jobs offered coverage. So my hope is to cover a few things here, just as we look at the structural racism hidden medical school curriculum. This is a survey of required lectures in the first 2 years of medical school. 350 required lectures in the preclinical years. They were analyzed to look for the mention of race, categorized either explicitly or implicitly. And out of the 102 slides that mentioned race, the vast majority was what? Biological risk, 96%, with 38% noting some difference and 58% implying biological difference. Only 4% acknowledge the social determinants of racialized disease disparities. So what would this impact have on our students? So those ideas and thoughts kind of get imprinted a little more, right? So this study was in 2015, published in 2016. It looked at if racial bias, when it came for the treatment of pain, is related to the false beliefs that people have about biological differences. Study one looked at white laypersons with no medical training, and participants were really asked how much pain they would feel and asked to rate across these 18 different scenarios. Study two looked at white medical students and residents and had the medical student residents look at these mock cases about experience and then do pain ratings. So what do they find? Unfortunately, many concerning things. So 50% of students and residents believed at least one of these statements was possibly or probably or definitely true, right? At least these students are believing that whites have larger brains than Blacks. A quarter of second-year students believe Blacks age more slowly than whites. And this last piece of, you see on there a couple of the different highlights. The press gained more impetus on Black skin being thicker than white skin, right? And this is not even that long ago. It just seems like that's quite a bit of frustrations we're seeing as we look into the known literature on what we're dealing with. The roots are rather deep in structural racism. So I'd like to explore some of the things that I think are of value to understand the context. So hopefully this will add a little bit more of those deeper roots to understand what's happening here. So some of the upstream drivers here, residential segregation, one of the primary drivers of health disparities. This quote by David Williams rings true. Social inequities are patterned by place and opportunities to be healthy. They vary markedly at the neighborhood levels. And really the culprit of racial housing segregation is a concept called redlining. And that's there in the mid 20th century. And if you wanted a book, I like this book, Rothstein's Color of Law. That's a full story. And so, to receive loans, mortgages, these developers and home buyers were directed to areas that were in harmonious racial groups. So Black people or white people. Red lines are drawn around communities, and white people did not get loans to build or buy houses in them, while Black people were given loans to buy or build houses there. And that legacy is still felt, right? Multi-generational households. So African Americans are more likely to live in multi-generation households and also immigrant communities where they have older family members who are considered high risk. So in the COVID-19 pandemic, you can see that stacking up concerns. And this is in your own area here. Black neighborhoods in your city bore the brunt of infections, right? And a large cohort of, in Louisiana, disproportionate hospitalization rates. And this gets into that unequal pattern of testing in neighborhoods as well. These food deserts where communities, it's high calorie foods. They develop diabetes, obesity, high blood pressure because of the options they have. And environmental racism. And so it's exposure to these pollutants that are happening. If you've not been to some of these sites, Economic Policy Institute, it's a wonderful set of resources there to look at what's going on. Unemployment skyrocketed for Black and white workers. The unemployment rate is much higher for Black workers. So this really shows that unemployment rate thresholds here. And we used to think of not the great equalizer. It's really, I really think of it as it creates more disparities than equalizing. And a couple more things I'd like to just get through in our slide deck here. Black workers are 3 times more likely to be in essential jobs than in non-essential jobs. So therefore, they're more likely to be in frontline jobs, risking their lives, right? And so not only are Black workers losing their jobs pretty fast pace, those who aren't losing their jobs are likely in the front lines. So this figure shows that Black workers make up what, 1 in 9 workers overall, yet they represent 11% of the workforce. And so 1 in 6 in healthcare is 17.5%. I like the adage that Blacks are the first fired, last hired, right? That's just a powerful statement that when I think through the data that's coming through. A couple more things before we kind of get into a couple other pieces of more, where do we go from here? 15 versus 5%. The percentage of Black patients with Medicaid insurance was 3 times as high as percentage of white non-Hispanic patients. At the start of the outbreak, 18 million patients are at increased risk of severe COVID, who are inadequately insured. So again, the key is that many, again, have insurance through their employers. But the hard part is you get more, if you have a job, you'll get insurance. Otherwise, you're gonna have issues with that. I like this quote by Hardiman and co-authors in New England Journal. Health insurance markets enable a tiered and sometimes racially segregated healthcare delivery structure to provide different quality of care to different patient populations. So our insurance system is rather challenging. So with that, I figured I'd go to Twitter because I have a colleague and consultant on Twitter who is helping explain this a lot more clear, I feel. So let me turn to him here.
People pay us money every month, and if they get sick, we pay for all their health care. I love it. Great idea. Okay, but what if people get really sick? I mean, that could be expensive. I know. They pay us money every month, but we only start paying for their health care once they get sick enough times. That's brilliant. And we call it a deductible. I love it. It sounds like down, reduce. Like we're reducing the cost of healthcare. But what if people don't have enough money to pay for this? I know. To have health insurance, you have to have a job. Oh, that's good. We're getting so much done today. But what about people that don't have jobs? How will they have health insurance? Hey, let's break for lunch.
Hope you enjoyed that. That's just the frustrations people are having and compounded by structural racism that's coming into play. All this links into a term called weathering that was coined by Arlene Geronimus. It describes a lived experience of being an under-resourced group, specifically in her original studies were African Americans, wear and tear from external stressors, but it could be extrapolated to any under-resourced group. It's been linked to quite a bit of things, right? It's been linked to cardiovascular disease, diabetes. Those are risk factors for severe COVID. So in our care of COVID patients in general, I'd like us to think through place-based risks and resource deficits. So those risks are pretty evident. You can see it on that slide. And so uneven geographic distribution of preventative care, access to healthcare, dense housing, hazards, insurance, you name it, right? And that's what leads to this concept. So it's a multifaceted problem. And this tree analogy, I like it, just the roots are deep here. So inequities affecting Black people lead to mass incarceration, high poverty rate. We haven't gotten into some of these other broader topics, right? And so access to testing and inequity in testing, decreased healthcare access, and inequities in worlds like I've done, telemedicine. I've seen inequities there as well. Who gets access to technology, etc. So this all links to individual access as well. And this event, as historic as it is and a pivotal point in our nation's history this year, this happened 5 miles west of where I live. And having this rock our world has been very emotional, jarring, but it's also helped me think through what are the pieces here that we should navigate into. And some of this involves personally mediated racism. And focus here is on how racism impacts some of our lenses, and particularly bias and its impact. And I'd like to share metaphors to help us grow in this area. So first is a mirror. As we look into personally mediated racism, we need to consider how our own identity, beliefs, and experiences impacts how we view the world. Second, a window. Remind us to think critically about how systems are at play and how others who are different from us may be experiencing the world differently. And then the concept of implicit bias and the related term cognitive bias that can impact various groups. I like the Kirwan's Institute's observations of these biases. Implicit biases are pervasive. Everyone possesses them. They're reinforcing, right? And particularly with regards to racism. The associations are sometimes not necessarily aligned with our declared beliefs, and sometimes we wouldn't explicitly say something, yet we tend to hold it. And generally, we try to do it hold on to implicit biases that are favoring our in-group. There's some research that goes the other way too. And fortunately, they're somewhat malleable too. Our brains are rather complex, and the associations formed can be gradually shifted. So that gives us some hope, but the work is hard and needs to be done. A few examples. This can be a whole talk in itself, but visceral bias. It is the emotional influence on when we perceive a patient as difficult, delicate, or somehow special. And I think African-American women, Latinx community and women are particularly impacted by this minimization. I think if you wanted a book to read, it's a sobering history of medical ethics is Medical Apartheid by Harriet Washington, and really tells us a lot about the visceral bias and the systemic disadvantages. Another example is fundamental attribution error, the tendency to be judgmental and blame patients for the illness rather than examine their circumstances. So under-resourced communities, specifically our Black and Brown communities, those with comorbid conditions like mental health, that just compounds things, right? And so they tend to suffer from this. And this links to base rate neglect and concepts that are a lot in the statistics, but it's a failure to incorporate what? The true prevalence of a disease into the diagnostic reasoning process. A young man is attacked at night and fatally injured. Who do we envision in our mind in these instances as a default? Is the attacker brown or Black person? Or are they a Caucasian middle-class American, right? Some of our strong emotions are activated by that, and yeah, the decision to act is that automatic, is predicated on automatic behavior. I'm going to walk into a couple of these cultural humility, cultural competency. I tend to like the word cultural humility a little bit more, but the National Equity Project use the word cultural competency, so I'll use that there. Each of us views the world through a lens, a set of lenses, right? It's how we read and make meaning of the world. So this graphic breaks us into the institutional, individual, different lenses that people have. They're interrelated. Individuals are born into structures, live in structures, work in institutions, biases are formed. And if these are the lenses, how do we understand our mindset? So this slide is meant to go through a framework that I recommend for many of our colleagues here, and I've been growing in this area as well. It's an illustrative of the developmental process to become more anti-racism, anti-racist, and address structural racism and individual racism. The idea of growing in any area of diversity takes a process, right? And this snapshot is about getting both exposure and intentional development. So there are 5 orientations I'd like to cover briefly, and then we'll go through an example of one and deep dive. The 5 orientations are denial, polarization, minimization, acceptance, and adaptation. So as we walk through each of these, denial is what? I am not really interested in experiencing differences. I'm fine the way I am. And so, thank you, just leave me alone. And so their mindset is really unable and unwilling to see differences. And so the organizational impact, I think, is diversity and inclusion. Racial issues are ignored. And so the developmental focus should be help people see the difference, awareness of racial groups. Most groups, I trust that Mount Sinai is not there either. They're probably well past that. Polarization, if we were to say, is the next step. That's when some points of view are obviously more right than the others. Maybe say these immigrant populations are always this way. It's one mindset is better than the other, kind of dualistic. It shows up in two different ways. One, the most common is defense. My culture is better. Why are they always this way? But also happens the other way, reversal. Their culture is better. People coming from long experiences abroad, sometimes coming back to a dominant society, etc. Oh, there's too much consumerism. We gotta fix it, right? So the organizational impact of polarization is they see diversity and inclusion as a problem or an obstacle, and it's an assimilation to the dominant culture is expected. So that's the challenge there. So the focus, how you can develop off of that is seek those commonalities. Then the transition point is really minimization. And that's when you're considering these valid statements, but simultaneously holding on to different worldviews. But you're de-emphasizing some of the differences still. And literature has been showing, and I think the groups have been kind of sharing with, there seem to be a fair bit of people in that pocket of minimizations. Many groups are there as well. But where do you go from there? If your group is there or pockets of your group are there, move to acceptance and adaptation. Acceptance is every individual has a unique background, racial background in particular. No one viewpoint is better than the other. They see the complex differences, but what's important there? They're curiosity and exploring, but they're not, they're talking the talk, but not walking the walk yet, or not able to walk the walk well. So the practical applications are needed there. And finally, adaptation. And that's when you're meeting others where they are, you're mentoring, you're culturally responsive with policies and procedures from an organizational standpoint. You're shifting the mindset all the way and adapting the behavior. And so that is that intercultural, ethno-relative mindset, right? And so it's a lot more there. So that's deep. It's a lot of work by Hammer and all, and over the years. But I put that in because we're going to deep dive on one area, right in the middle, minimization. So picture this. It's in our hospital. And some of this work, I want to thank Dr. Kimberly Manning for giving me an idea on, yeah, this is something we see all the time. And we walk into on our wards, imagine this. Imagine there's an attending physician, a senior resident, a resident intern, maybe medical students, bedside nurse, all entering the room with their masks on, physically distanced as able. The patient was admitted for COVID. Everyone on the team is dressed identically. All have their PPE on, masks and gowns. And as this team approaches the bed, the patient looks over at one of the members of the team, pushes the food tray away, and says, "I wasn't really hungry. Please take that away." So, well, the person that pushed the tray away towards was the intern physician. She looked similar to other members of the care team in the room. She was the only woman in the room, and only one other thing was different. Her ponytail was made up of African-American braids, so African braids. So what happened? In the moment, she froze and said, "Oh, well, I'm actually the doctor taking care of you," and looked at the rest of the team to see if they were going to do something, right? And really what happened next is what happens throughout the nation, and from Dr. Manning's story as well, it happens elsewhere. People just carried on their history and physical and walked out of the room. And it's in that debriefing process that you're hearing the struggle and the pain that's going on. And the words that this intern started saying, "I wish someone said something. That's when someone didn't say something is when I felt so awkward." This happens every day. And so the framework that some of you have maybe heard about, it gets into the topic called a bystander effect, right? And this is getting from personal mediated racism, how do you actually move into an action? So what if this were to happen? Maybe you've heard of the term microaggressions. What if that were to happen? It's a polarizing term, I understand, but what happens if that's the case? A framework that's been used in the literature is there's a what, when, and so on. So the what is meant by you being a bystander or an upstander. So we'll talk about that term a little bit more. And when, we'll talk about when do you have these opportunities. We'll talk a little bit about, sorry, let's repeat that. And then the how. How do we actually process through that? So the word bystander is a chance spectator. You guys have seen that quite a bit. And so this happens, and you've seen that a lot in the known literature in this last year. And onlookers, you're a chance happenstance person that's there. So this happens in a group, and if you were to look at the known literature on this, in cardiac arrest, for example, if you're just by yourself, usually you shout and say, there's something going on, we got to do something, stop for help. But what if it's the group size increases in time and you become more and more passive, right? And so especially those in marginalized groups are those that are often needing help. And the studies have not necessarily looked at that space more, but in the cardiac arrest literature, it goes from in the 70 to 80% all the way down to 30-ish%. And I put this GIF in none other than I like carpool karaoke with Corden and Will Smith, but it's also the idea, it's pretty lackadaisical. People just go on their way, they're listening to the music of that day and forgetting that there's actually something going on that's much more deep. So why does that happen? So a lot of things have said a couple of reasons why this minimization occurs or this bystander effect occurs is on a bedrock of structural racism. Yet some of it's diffusion of responsibility. When more people are present, they'll take care of that. And so I deal with it in my house daily. I have kids that are in middle school, and who's taking the dog for a walk? It's diffusion of responsibility. There's 3 kids, and they'll just, one of them will thinking the other one is going to take care of it. That's a silly example, yet in the hospital, bystander effect, that sometimes happens as well. Someone else will take care of that, and I'll let it be. There's perceived cost and apprehension, and I share it here, and try not to be nervous because you know, there's probably expertise in the room that knows a ton of background around this topic itself, right? At some level, I try to say, I'm growing in this area, and when I were to see something happening in a clinical environment, maybe I should be the one calling up and speaking up. Should I be afraid that others who know more than me may want to say something different, and I'm afraid about the cost. And sometimes that muzzles us from speaking. I think of non-attendings, our trainees, our non-physicians, and there should be more of a speak-up culture that's built. And I hear that that's being built quite well at Mount Sinai. Ambiguity. How do you know if that's sensitive or not? Did I hear that right? Then there's the social influence. Because no one's helping, maybe the situation is not helpful at all. Maybe it's not as important. And this gets into those biases of blind obedience, confirmation bias, etc. And then there's implicit bias. We chatted about that. That structural piece that is going through, that the literature is starting to speak more into, that this is probably playing quite a bit of a role. So, and I really just like to say our lens comes back to our lens. How we see the world will actually help our individual exposure. So the ways the known literature has mitigated this is through diversity, exposure, bias training, cultural humility. And then we ask the question, why does this matter? So if you're still not convinced that microaggressions are a concern and there's potential for minimization, I'd like to share with you one clip here. Let's see if we can get to that.
For people who still don't think that microaggressions are a problem. Oh, you're so well spoken. Oh, just imagine, instead of being a stupid comment, a microaggression is a mosquito bite. Ugh, it's a compliment. Mosquito bites and their itch are one of nature's most annoying features. But if you're only bitten every once in a while... No, where are you really from?
Cleveland.
Sure, it's annoying, but it's not that big a deal. The problem is that some people get bitten by mosquitoes.
Sorry about that. Let's see if
For people who still don't think that microaggressions are a problem, oh, you're so well spoken. Oh, just imagine, instead of being a stupid comment, a microaggression is a mosquito bite. Ugh, it's a compliment. Mosquito bites and our itch are one of nature's most annoying features. But if you're only bitten every once in a while... No, where are you really from?
Cleveland.
Sure, it's annoying, but it's not that big a deal. The problem is that some people get bitten by mosquitoes a lot more than other people. I mean, a lot more. Whether it's on a date...
Oh, your ring was so good.
Excuse me? Going grocery shopping. You know, everything happens for a reason.
I'm just fine, yeah.
Commuting to work.
So when are you gonna have a baby?
Watching TV.
We have to keep the Redskins name. It's part of our culture and history.
Or just walking down the street with your partner.
I couldn't even tell you were gay.
Mosquitoes seem to pop up everywhere.
You know John and you shopping advice with bad news.
Of course, beyond just being annoying, some mosquitoes carry truly threatening diseases that can mess up your life for years. Astrophysics? Maybe you should try this challenging major.
Oh,
And other mosquitoes carry strains that can even kill you.
It looked like he was up to trouble, okay? I felt threatened.
So next time you think someone's overreacting, just remember, some people experience mosquito bites all the time.
You're all so exotic. Wow.
And by mosquito bites, we mean microaggressions.
All right. No, that's a powerful analogy, a little comedical, but it actually gets to some of these things. So some real cases as we kind of look at this, again, names and pictures, everything is changed up for this purpose. A situation when we had a colleague who was looking, doing some chart review and saying, you can just look at the last name and the new admissions coming in and saying to the colleague next to them, you can look at the last name and tell from this person that I don't think this is going to be an easy admission. Get ready to get a lot of cross-cover calls all night long. And this patient that they're looking up was from East Africa, and what they did not know was the medical student that was in that room is also from East Africa. How about this? What's with this fast? This patient asks one of our Muslim colleagues and saying, during Ramadan, do you guys not eat all day long? Wait, I really don't get it. What's going on with this Ramadan? To one of our Asian colleagues, where are you from? No, really, seriously, where are you really from? You speak English so well, but you're so quiet. I need to hear what you're saying and thinking. You need to have a louder voice like this other doctor, and names another doctor from a different ethnic background. Speaking to one of our housekeeping staff, it was said, you are so tall. Instead of working here, you could have played professionally, made a ton more money. So on and on, right? And so where do we go from here, right? And so some of the frameworks we've done is from social psychologists, and I'll add a pearl from Dr. Manning from Emory as well. First, you need to notice, broaden the lens. Did a microaggression occur? Then I would say evaluate. What happened here? Interpret what happened. Assess for context and safety. And then the third thing I would say is respond. And that's where I'd recommend the framework of the Ds. And we'll walk through that in a brief bit here. So the kind of the Ds are the following. Direct. So for some, this may not fit. So it's using I statements. What's going on here? I feel a little bit uncomfortable by your statement. It's being firm, concise, and clear. And oftentimes the person that's saying it is often not aware. And so it's surface communication. It's kind of usually subconscious meta communication. So you're bringing that out into the visible a little bit more. So the invisible becomes visible is the main piece of a direct. You could distract. You could change the subject. You could use humor. You could shift the focus. You could delegate. I'll say you want to speak to someone else. You want to maybe document and tell it later because that's not the right time. You could check in later. You could say at this present time is not the right time to address this. I want to check with my second victim who is probably, I heard this and was directed towards, and I'm going to follow this up later. But I say one other thing that Dr. Manning had provided in one of her talks is this: display discomfort. And that's pretty, it's showing some level of discomfort. maybe tilting the cue to someone else. Oh, I don't know what that's about. Body language, that didn't come off right. That's something I think is a powerful D as well. So recall that story we started with. Remember the microaggression that occurred there? Recall that intern freezing. Recall no one else saying anything, right? The tough part in that story is I was the attending in that room. And I froze, and I minimized it, right? It was gender and racial microaggressions that occurred there, yet I did not respond. And I think this is humbling work, this is mutual work, and we need to do it, but it starts with me. So as you're hearing these things, feel free to reflect and say, this needs to begin in my footsteps as well. I need to continue the work of being an upstander. So as I come to where do we go from here, slides, structural racism. The National Equity Project has done a ton of work on this. The history leads to the practice, leads to the disparate outcomes, leads to the internalizing bias, leads to more policies that reinforce, right? And so as individuals, we should practice anti-racism. We should notice, evaluate, respond, broaden your lens, remember the 5 Ds. And I think leaders with the courage to respond is key. And so individual leaders need to step into these spaces. And in medicine, many of us are leaders. From our hierarchy, as flattened as it can be, it's still, there's a hierarchy in medicine. And I think many people will listen to the voices of our medical care providers. And even thinking through what can we as individuals move into systemic things, what are the levers in medical education, healthcare provider systems, and payers that can be pulled for this. Institutions, a little more complex, but are we applying a racial equity lens to all of our policies and procedures? Where do we expand our and contract our resources? What do we use for quality metrics? How do we support access? And this is a talk in itself, or has been a talk in itself, but the whole concept of where do we denounce this? And some of it is in amazing literature that's been coming out through the last couple of years. San Francisco General Hospital, Monica Han has some great work. Race itself is an indicator of exposure. So at some level, as you go through it, race is useful when trying to define disparities, but racism and decision should not be made through certain pieces of structural racism that's been embedded in there. People have gone into the EGFR, is that something we should be using, et cetera. So I love that the literature is starting to expand in that, explore it, and some institutions, Stanford and others, have started to make those structural changes with that. I'm going to leave some time for Q&A, but I want to end with a couple of recommended reading lists. Racism 101. These have been great books over the years, and some of them are recent books as well. Structural Racism 101. Racial Identity Formation is another one that you can walk through. So if you haven't done maybe book clubs and other things, these are ventures to go into. Sounds like you've done a lot of things with your medical training program, with your residents and faculty in separate venues, maybe bringing them all together and having them discuss collaboratively would be one thing. A lot of my residents and students have taught me a ton on this. I feel like the curriculum have moved quite a bit on this space in their generation, much more than those of us who've been 10 to 15 to 20 plus years out. Then it's, well, you're kind of fending for yourselves to figure out how this could be dealt with. So we've been through rapid fire pace. Hopefully that went okay for you guys. Begin to understand how structural racism works in medicine. Examine how our own biases can contribute to racial inequities. Work on being anti-racist ourselves, looking through the frameworks of going from denial all the way to adaptation, from an individual and a organizational lens. And how do we as hospitals and health systems become more anti-racist, putting a racial equity lens. All right, I'll pause there. I'm available on Twitter. I'm happy to take some questions or build a conversation. I'll just put a prelude. I will not have all the answers. And that's been known for many years. And so I hope that it's a conversation that we can continue. Thank you.
Dr. Mathews, thank you so much. So we have a few minutes for questions. If people have questions, they can either unmute themselves and ask, or put something in the chat box for Dr. Mathews.
Hello, Dr. Mathews?
Yeah.
Oh, can you hear me? This is Shamit Patel. So the way I see it, recognition of implicit bias is an act of higher learning, and getting it to filter down to day-to-day activities is difficult because it is based on individual experiences learned over a lifetime. And trying to change this is incredibly difficult because professionals function using heuristics, and increasing awareness does, I think, does create long-term change, but I think that change happens over years. I don't know if it can be changed rapidly over a whole system. And I don't know what your thoughts are on that.
Yeah, great. Love, thanks for the question there. And I'll take another, it looks like another one coming through the group chat. Heuristics and biases, that could be a separate talk in itself. And I think the literature hasn't been too clear on it. You know, historically, if you look at cognitive biases and biases in general, it's not very malleable in the setting of cognitive biases for diagnostic performance improvement. So most people sit in certain types of thinking, type 1, type 2 thinking, but, and I don't know if the group has context on that, but the idea is that, well, if it's not malleable in diagnosis, is it malleable in things like implicit bias? And the literature actually is starting to grow into that. And some of the older ones seem to be saying that it is malleable, and through things called exposure control. And your question, does it take years to undo? Some may, but it's also types of exposure. It could be sentinel events. It could be sentinel moments. So events and moments are the things that come in. So say you've had a historic bias, unbeknownst to you, about a certain people group. I'm just going to pick African-American people group. And then a sentinel moment happens in your life. You marry someone of African-American descent. Or you're like, that can't be even true. You marry someone like your background, but you end up adopting or having connections with, your kids have connection with someone else. So those sentinel moments occur and start molding things. Depending on how large that inoculum is, it can often change things pretty quickly. So I have hope in that. It's a good question. I don't think the literature has been proven on that. I'm open to learn from it if some of you have found other pieces as well. It's a great question. I can field this question. Can you give an example of how you would have intervened in that example you gave? Great question, yeah. So that was a humbling, I mean, it is pretty similar. I took out some of the features of maybe gender and a couple of the things that twisted it a little bit. It happens frequently, right? So I use that 4 to 5D framework here. So it depends on the context. Do I notice it first, right? If I've noticed it, assuming we've noticed it, I try to evaluate, is this the right moment? Is my manner and matter going to make a difference here, right? Is the room safe enough for this? Is that patient, or is that other colleague in the right space to address this? If I have a relationship, if I have a relationship with my resident and I know my resident well, and this is dear to their heart, or this is their identity and formation, I tend to be an advocate in that room, and I'm usually direct. Now, that may not happen easily for others. I'm a man, I'm over 6 feet in a room, right? So I have a body presence that may be different than someone with a different gender, different body figure. And so then how do you make direct comments? Does that change the hierarchy in the room? So I tend to say those Ds, I don't think there's a right answer on the Ds, but I think the opportunity to respond, I think, is an obligation for us. And secondly, I'd just say is that structure is set up to help applaud that. If there's not a speak up culture that something happened here, are we calling this out? Or are we doing something about that? If that's not set up, and that takes some time in a system to build up, that can get at. So I would say in that situation, that specific situation was a challenging patient encounter, and I probably would have moved towards a delayed follow-up. So I'd say, okay, this happened. I try to distract quickly. Okay, let's move on. And then I come back and talk to our intern resident right away and say, hey, this is what happened. How can I should hopefully a couple things, kind of circle back one more time. Show discomfort, distract, and then delay. It's probably the ways I'd kind of go at it, not the direct piece. Hopefully that helps. There's another question, and can you give an example of how you would let a supervisor or a superior know they have done or said something that is a micro or macro aggression? Great question. That gets the question again gets at how do you manage up, right? If behaviors by someone who is at a different hierarchy from you, Are they going to be open to it? So I work with, in that framework, similarly as well. So it's, again, power control, power dynamic, and say, is this something that is, again, safe? Are they noticing? Are they aware of it? If it's truly implicit, and I tend to see, are they open to feedback? Is this an opportunity where they've allowed an opportunity to talk about it? And I try to see, are they in a spectrum where they would be open to something direct, as an example, and say, I was uncomfortable. I was wondering if someone could have said something then. That could have helped something. If there's an opportunity for, I encourage that in our culture with our teaching staff, having an opportunity where the students, residents can truly give feedback to you for our group so we can improve. That can help. I think getting into there are times when that is not possible, when the culture is not set up where a medical student who's trying to get their rotation grades, et cetera, I don't know if that's how it's in your institution here, there's high performance anxiety, right? You're trying to perform, and then you come into a place, and how do you give feedback to an attending? And as sad as that is, it is the reality of sometimes. And so in that situation, I tend to go to allies. Is there a resident? Is there someone else that could partner with me to bring that feedback back to that attending? Would be the way to go with that. Hopefully that college try at that one. All right. A couple more questions. Are we doing okay on time, Dr. Wiseman?
Yep, perfect. About 7 more minutes.
Okay, our political social climate has shown us the importance of both recognizing our biases, but also moving beyond this to develop anti-racist policies and procedures. Do you have any examples of anti-racist policies and procedures you've seen other health systems employ? Oh, I love it. Yeah, I think there are examples. I didn't put in an extra slide deck. There's examples of societies taking stances, and sometimes if organizations or departments often can move into aligning with a professional society stance. So this is ACP, or this is what, and I'd like to move into that domain. Organizations that have done it well, I think abound. I think places that how they've done it is a little tricky. So sometimes it's grassroots. So they've have a subcommittee that's set up with the diversity, equity, inclusion group that walks into, this is a framework for how to set up a speak up culture. If this were to happen at any level, from anyone who has a touch point with a patient, this is how you enter. And some of the successful groups, at least in the Twin Cities, they moved into documenting and putting it into a system that then tracks it. The challenge I have, that may be good and does get to ticks and clicks. It may not get into a safe culture of speaking up without a blame culture. So I want to encourage both, and where there's a documentation, there's a speak up culture, but there's also a, not to minimize, but to how do you actually explore conversations and grow together. And I think that's probably one of the steps organizations can take. On the ground training with people to do implicit bias training. I think sounds like your groups have been doing work in that aspect. Workshops on microaggressions and script building. So this happened, let's document. We do that for mock codes. We do that for rapid responses. We do that for diagnostic reasoning, right? We think through our cases and have morning reports, noon conferences. We should have similar things. Diagnose what happened in this room. Let's work through this. What's our differential? What's our action plan? That takes effort and practice. So as you're saying, what would I have done? A lot of these things is script building and developing that in the process. So I'm more of a diagnostic reasoning guy, so that's how I've been thinking through it. But policy and procedures are important. And rather than calling out some of these places, feel free to reach out to me in an email. I'm happy to send links or contacts to people that have been working on this longer than even the Twin Cities here.
More questions for Dr. Mathews.
I'd love to hear, I know I didn't get a ton of time asking Dr. Wiseman and Dr. Steinberg, who had invited me to this. I don't know your climate in different domains. Is this an opportunity to maybe hear, cross-learn a little bit from me too? I've heard a little bit, but I'd love to hear your dream state. And it sounds like this is a great opportunity bringing the community together for this, this piece as well. I'd love to hear what you
Sure, and maybe I'll turn to some of our residency leaders to talk about what's existed in the sort of residency training program. I know the hospital leadership has taken a pretty firm stance to make sure that we've always been a very diverse organization. We were founded, both Beth Israel specifically and Mount Sinai in general, were founded to address the needs of religious and ethnic groups that weren't well served by the other hospitals in New York City. And I do think there's a very strong commitment to continuing that work. And, I, as part of the leadership group, have certainly done a lot of trainings around this. And I think, the trainings are happening in kind of, as I was saying before, overlapping, which I think is great in the sense of making sure that people are hearing in different venues this important material. And I think as we sort of figure out how that turns into real action and what we can do, and maybe Matt or Christina or somebody can add a little bit from the residency point of view what else we've been doing.
Yeah, of course. Thank you very much for your talk, Benji. It's really an excellent sort of framework to be thinking of and some tips to employ in our daily experiences. As far as the residency program is concerned, we've been developing a health equity curriculum when we talk about the sort of structural determinants of health, sort of moving on beyond the social determinants of health. But part of my question about explicit anti-racist policies and procedures was I think that we all recognize that we need to be moving beyond curricula. We certainly need to be creating spaces for the conversations, and that's what we try to do in the primary care curriculum. But I'd like to be, again, moving beyond that. I think over the next few weeks and months, we'd like to begin to give residents their quality data in the primary care space stratified by race, just so that they can see differences in that space. Obviously, the disparities is sort of the manifestation of everything that we're trying to get at the root of, so that we can begin to get at the root of it. And I think, that's one of the next strategies I hope that we employ. And part of my question was just sort of trying to wrap our brains around what else we can be doing and should be doing.
Yeah, that's great. I love that reflection. And I think some of it's, if you can get to that after awareness building, moving into drivers, and can we get at measuring those? So we're working with our ER colleagues now to say measuring door to time seen for triage for our patients of color, non-English speaking. And then also there's a trend that they're being seen later, but they're also leaving earlier. So what's going on there? And that's been a data and trend for years and years. So something, even with some of our initiatives over the years, has not changed that. So let's go at some of these things that we measure it, track it, and improve that with an intervention. So it takes time. So again, we're happy to collaborate as a community hospital. If there are ideas that any of you have, or build a network that we learn from each other, is one of the ways we can do this together.
Great. All right, that sounds like an excellent stopping point. Thank you so much for joining us, and we look forward to continuing this conversation.
All right, thank you, everyone.
Thanks, everybody.